Well, good morning. This is Tuesday, March 17, the year of our Lord 2026. The Insurance Committee of the Tennessee House of Representatives of the 114th General Assembly is now in session. Members, please remember to sign in. Do we have personal orders?
Take the roll first.
Chairman Hale, you're recognized.
Take the roll first.
Thank you, Chairman.
Okay.
We have some folks from DeKalb County. Our DeKalb County leadership is here for their day on the Hill. So if y'all would help me make them welcome this morning to committee.
He says take the roll first. Is it Mr. Clerk or Madam Clerk? Kindly open the roll. Members, register your roll or your presence. Clerks, please count the roll call.
Mr. Chairman, you have 15 members present. You have a quorum.
Thank you. Going back to personal orders, Chairman Terry.
Thank you, Chairman. And, I don't know if it's St. Patrick's Day or the fact that you've won the Masters, but you're looking pretty spiffy right here. So,
Well, thank you. I have instructions about this being St. Patrick's Day and to open it with the Irish prayer. I, as you can tell, am an honorary Irishman. I have a button to prove it. The Irish prayer that I was given this morning is, may the dreams you hold dearest be those that come true. May the kindness you spread keep coming back to you. God bless you all. We will move on with that sentiment to our calendar today. Is that right? Okay. We have a number of bills on the calendar, but we're going to take the first 8. The rest of them will be rolled to next week. That is because we have 10 care presentations today. The first bill that we have on the calendar is House Bill 2619 by Chairman Howell. Chairman Howell, we have a motion and a second. You're recognized on House Bill 2619.
Thank you, Mr. Chairman, and I do like the green jacket as well. Mr. Chairman, I do have an amendment.
Yes, we have 2 amendments. First one is Amendment 014046.
Yes.
We have a motion and a second to attach that amendment. Members. So take a second first. Okay. I'm advised to choose between the 2 amendments. Do you have a choice, or I'm told the second amendment contains the language of the first?
Yes, that's correct.
Okay.
My amendment is 015618. That's the one I would prefer.
Members, kindly give me a motion and a second again for Amendment 015618 to attach to House Bill 2618. All those in favor, please say aye. Amendment goes on the bill. Chairman Hall, you can explain the amended bill to us.
Thank you. And members, the reason that I have an amendment is because the Tennessee Department of TennCare put a $138 million fiscal note on this bill because the original bill included a clause that required reimbursement equity to health providers. For example, the bill said originally that if provider A performed an EKG on a patient and the insurance company paid them $200, this is an example, then provider B should not be paid $100 for the same service when they have the same license. So by putting a $138 million fiscal note on that section of the bill, TennCare has admitted that they are not paying health providers the same money for the same service. And by not doing so, the big insurers who manage TennCare's MCOs are pocketing $138 million, which should go to providers. I'm just making the committee aware of why we have a fiscal note on this bill. So I'm glad that we have this admission from our Department of TennCare. But the good news is the remainder of the bill is intact. And I would like to explain some of the things that it does and then take questions. I call it the patient's first bill. The bill is about fairness, transparency, accountability, and health insurance. Patients deserve medical decisions made by qualified professionals and not AI algorithms, which is happening now. Insurance companies cannot let AI deny its policyholders the care they need without some kind of medical oversight. They need eyes on the claim. It's been estimated as high as 81% of first-time claims are denied by AI. That's absurd. A qualified health provider must review and approve any AI-based denial in this bill if it passes. It prohibits sending a patient's medical information outside the U.S. for a claim review. It's been estimated as high as and as low as 33%, as high as 61% of coding is sent outside the United States to who knows where. You'll find this language on pages 11 and 12 of the bill. This bill creates independent oversight. It creates the Tennessee Commission of Insurance Review on pages 4 and 8. The commission will hear complaints, investigate wrongdoing, enforce the law through the Attorney General's office, especially when an insurance company practices medicine without a license, which, by the way, is illegal. But it is happening, and it has happened to me. It stops downcoding and underpayment. We have a major hospital in this state, in Representative Hicks' district, that is owed about $65 million from a major insurance company. My own hospital in my district is owed $64 million by a major insurance company. And we need independent review over these situations. It provides a 60-day notice for contract changes. That's on page 9 of the bill. Recently, I believe it was in December, may have been November, my hospital was notified by United that they were no longer in network. Overnight, I had about 8,000 of my constituents who have to now drive about 45 miles to be in network to get medical care. There needs to be a time frame on this, and 60 days, I think, is generous. It stops loss lasering. For example, if an insurer cannot single out individuals who are in a group like our employees are here, they're in group insurance, an insurance company can no longer single out an individual who has higher claims. They must treat them the same. And finally, it provides ownership transparency. We have situations, I'm sure many of you have heard, where insurance companies are buying up provider networks. For example, I'll just give you one example. There are many. United, the largest in the nation, I understand, who is currently, I believe, under investigation by DOJ. They're buying up provider networks. They've bought some here in Tennessee. And we have situations where if you're in that network and they own the provider, they send you to that provider network. And so they're basically in actuality paying themselves. And so this says that if an insurer owns a healthcare provider, the ownership must be disclosed to the patients, to the regulatory agencies such as the commission created by this bill, and to the Department of Insurance. In closing, the bill does not eliminate innovation. It does not prevent insurers from managing costs. It simply ensures that decisions are fair, transparent, and accountable, and I respectfully ask for passage.
Thank you, Chairman Hall. Members, you've heard the explanation. We have members who want to elaborate or ask questions. Representative Parkinson, you recognize.
Thank you, Mr. Chair. And Mr. Chair, before I ask my question to the sponsor, is TennCare on the list to speak? Because I have some questions for them also.
They are available. No, they have not made themselves available to speak or defend
Okay.
themselves.
So thank you, Mr. Chair. And Mr. Sponsor, thank you for bringing the legislation. Can you tell me why TennCare would pay one provider more for the same service than the other?
Chairman Hall.
Representative, that's a question I've asked, and I've got no response. I don't know.
And Mr. McIntyre, you mentioned I don't want to speculate because it went past me so fast, but it was interesting. Something about someone practicing medicine that's not, or an entity practicing medicine that's not licensed. So you want to elaborate on that
I'm
a little
talking
bit?
about, excuse me.
You recognize.
I'm talking about insurance companies. Insurance companies you have insurance, I'm sure. You have a contract. It's called the policy. Policy says they will pay you certain things for certain illnesses or certain situations that you have with your health. In my case, if I may give you my example, about 2.5 years ago, I was doing a good thing as a husband and planted a tree for my wife because I love my wife. And the tree's still growing, but I tore 2 meniscus in my right knee. And so I go to my doctor who's been in sports medicine, and he's a good surgeon, been doing it for 25 years. And he looked at it and said, "You're going to need surgery to repair your meniscus." The x-ray showed that I needed surgery on my meniscus. So to make sure we go to an MRI, I got an MRI on my meniscus, submitted it to the insurance company, and they said, "Nah, he don't need surgery." He needs PT for about 9 weeks. I'm not a doctor, but I'm not stupid either. That's practicing medicine without a license. They've completely removed the patient-doctor relationship, and they tell us what they're going to give us and what they're not going to give us, and it's time that we faced it head on.
Okay.
And I've got numerous examples, which I won't go into here, but that's what happened to me. And if it's happening to me, imagine what's happening to your constituents in the state of Tennessee.
All right.
Representative Parkinson.
Thank you, Mr. Chair. Thank you, Mr. Sponsor.
Representative Raper, you're recognized.
Thank you, Mr. Chair. In subcommittee, I described this bill as being one of the best bills that I have seen since I've been here as a legislator. I still think that. Number one, I feel like that what you're describing, Chair, is a dictatorship. You know, it's upon them and AI to make all the calls, and your physician, your surgeon doesn't get a say-so. I mean, talking about absurd, how can that be? How have we degraded to the point that it has gotten to where our own doctors cannot have a good say-so in what's going on? So I applaud you. Fantastic description of the benefits of this bill and straightening up things. This is awesome. I congratulate you again, and I beg for it to pass. Thank you.
Chairman Hall.
Thank you for those comments. I guess I should mention that I did get the surgery because I'm walking good today, but it delayed my quality of life for about 2 months because I had to appeal several phone calls, some very frank conversations with some people in the health insurance company. Finally got it changed, but our citizens should not have to go through that. When you've got 81%, I was a first-time claim. When you've got 81% of your first-time claimants being denied And only about this is polling that I'm telling you, only about 1% of them understand how to even appeal. Where's the money going? Maybe that's why United Healthcare made $9.7 billion last year. This is something that our constituents want. The polling numbers are there. This is near the top of the list of things they're concerned about, and we need to address it head on. I don't believe our Congress is going to do anything, so I believe it's up to the states to address this. And if enough states do, we'll get something done.
Well, thank you. You're describing situations in this bill that are not uncommon at all,
Yes.
and we've all heard the stories. Thank you very much. Chairman Martin, you recognize.
Thank you, Chairman. And thank you, Chairman, again for bringing this bill. You know, guys, as a healthcare provider, this is something we deal with every single day in this state. But more frustrating is when I go back and talk to my constituents, and 80% of them agree that health insurance has to be reined in.
Right.
There should be a comfortable tension between providers and insurance. That's just how this world should work. But when the pendulum has swung so far in one direction, this is what we're seeing and what we're hearing from our constituents every day. So thank you for speaking on it. Also to all the provider groups that actually came together to work on this is
Yes.
massive. I've been here 4 years. We're finally moving in the same direction of our patient-centric approach to healthcare, and that's not what's been going on. So thank you again. So we can get back to the patient. That's the key of what we're supposed to be doing. So thank you for bringing this.
Thank you.
Thank you. Chairman Terry, you recognize.
Thank you, and thank you for bringing this bill. This is a great bill, and I may be able to answer a couple of questions that were put out previously, but I'm disappointed in that the fiscal note that we're having to deal with because this bill, one of the biggest issues we're dealing with is the rural health care. And this bill still is a great rural healthcare bill, but this disparity in payments and providers, that is what's hurting rural healthcare because they are disadvantaged. Now, I don't know if many members remember this. We had a TennCare committee. I think Matthew Hill was our chairman at the time, and during that, we had one of the presentations. They talked about they did have this disparity in payments, and it may be different regions, but particularly in rural areas, and they don't have the bargaining power, and so they have a lot more TennCare patients. They have to take care of those patients. The MCOs know that, and so their rates will be lower because they have to take them. And so we now have those numbers, which I'm thankful that we do, but that's something that has to be addressed if we're going to help our rural hospitals and our rural providers and our rural groups. It has to be addressed. And so thank you for bringing this bill. I'm in full support.
Chairman Hall.
And I might admit, I might comment rather that the amendment that we put on does remove the $138 million fiscal note. There is still a fiscal note on which we will work on in finance, which is not insurmountable. But you're exactly correct. This is impacting rural health tremendously, and we need to address it.
Well, members, things do have a way of working out to some extent. After we do our first 8 bills today, we have allotted time for the TennCare MCOs to come and talk to us.
Good.
So I think they are already in the room, I would think, and I think that would lead to a discussion and an explanation. I think the timing is just right. Thank you for bringing this. Chairman Speaker, you're recognized.
Thank you, Mr. Chairman. Move previous question.
What happened? What happens then? You're very generous. Chairman Speaker will withdraw it.
Thank you, Chairman.
Representative Parkinson, this is your second go.
Thank you.
Okay.
And thank you, Mr. Chair. And it's such an interesting topic, and I appreciate you giving me a second. Hey, Chairman Sapicki, thank you so much. Why do you think TennCare chose to choose the higher rate that created the fiscal note versus the lower rate that would have showed the savings to the state of Tennessee?
Chairman Hall.
Well, I'm glad they're going to come and testify. You can ask them that question. I don't have a clue other than the fact that if they had not put the fiscal note on, we would have a way to lower the rates for our constituents, hopefully. But that's not what's happening.
And just quick follow, on a different note. You're creating you're creating an insurance committee in this bill, right?
Yes.
Is commerce and insurance, are they not,
This is-
tasked with doing that, or am I?
Chairman Hall?
No, this is an independent commission of insurance review. It's a place for people like my hospital, who's owed $64 million, Ballard Health, it's owed $65 million, or people like me who was refused surgery on my knee to go and have a hearing in front of this independent board. And if they've broken the law, it'll be enforced by the Attorney General. I can tell you straight up that the Department of Insurance doesn't want this.
Okay. Okay. Thank you, Mr. Chair. Thank you. And
Thank
Chairman,
you.
thanks.
And if I may, in closing, I'm sorry,
We do have another remark.
I'm sorry.
If you would
I'll
allow.
wait.
Chairman Speaker, you're
ju-
recognized.
Yes, thank you, Mr. Chairman. Just to follow up on what my colleague said over here about the finances. Members, we've been sitting on this committee for years now, and TennCare reverts tens of millions, if not hundreds of millions of dollars back to the general fund. There has to be a way for TennCare to look at that reversion number and figure out a way to fund this bill with the funding letter. Because they keep reverting tens of hundreds of millions of dollars back to the general fund that we just use mysteriously to balance our budgets. So maybe we could put that money to use on your bill, Mr. Chair. Maybe you need to remind finance about the reversion numbers when you get there and ask them to find the money for this bill in finance.
To your credit, Chairman Speaker, you have been mentioning this point, and hopefully we will discuss it again in the presentation. Chairman Hall?
To your point, in fiscal review, I just happen to be co-chair of fiscal review. But in the documents that was submitted from TennCare to add additional money, fiscal note to this bill, they admitted that $16 million that they earned annually from downcoding, which is what this bill addresses. So you're not incorrect on that. And I would ask also that maybe you might want to ask why, since 1999, total family health insurance premiums has risen 342%, while overall inflation grew by just 64%. It's no wonder they're making billions and billions and billions of dollars annually off the backs of the people who are paying the policy premium. And many of them in my district in rural Tennessee are struggling to make those payments. Healthcare is very important to our constituents, members, and we need to face this head on.
Thank you. Once again, I compliment you for bringing in common difficulties and problems that our constituents face. This is an effort to address those issues, and I think we are on the road. Thank you again. Representative Raper, did you have another remark?
I'm just going to call the question again, please.
Thank you. I was headed there too. Members, so without objection, question's been called. We are voting on House Bill 2619. Kindly, clerks, please open the vote, and members, vote your will. Clerks, please count the vote.
Mr. Chairman, you have 16 ayes, no nays.
Thank you. House Bill 2619, having passed, goes on to Government Operations Committee. Thank you.
Thank you, Mr. Chairman, committee.
Next item, we have second item, House Bill 1864 by Chairman Gary Hicks. Chairman Hicks, we have a motion and a second, and you're recognized on House Bill 1864.
All right. Thank you, Mr. Chairman and committee. And I believe I have an amendment that we need to add.
Yes, we have 014398.
That is what I have.
We have a motion and a second on Amendment 014398, attaching to House Bill 1864. All those in favor, please say aye. Opposed? The amendment goes on the bill. You can explain the amended bill to us.
All right, thank you, Mr. Chairman and members. This is the annual nursing home assessment, and I will answer any questions. Thank you. Thank you.
Members, do we have any questions? Seeing none, without objection, we are voting on House Bill 1864. Clerks, please open the vote. Members, register your vote. Clerks, please count the vote.
Mr. Chairman, you have 16 ayes, no nays.
House Bill 1864, having secured the majority vote, moves on to Government Operations Committee. Thank you.
Thank you.
Next is also Representative Hicks's bill 1867. We have an amendment. I have 013417.
That's what I have, yes.
Okay. We have a motion and a second on the amendment. All those in favor of attaching amendment 013417 to House Bill 1867, please say aye. Opposed? Amendment goes on the bill. Chairman Hicks, that you can explain the amended bill to us.
All right, if you like the previous bill, you're going to love this one. This is the annual hospital assessment. I stand to answer any questions.
Well, that's an
I hear you.
that's an easy step.
Thank you.
Previous question.
Okay. Previous question's been called without objection. We are voting on House Bill 1867. All clerks, please open the vote. Members, register your vote. Has every member voted? Does anybody wish to change their vote? Seeing none, please count the vote.
Mr. Chairman, you have 16 ayes, no nays.
House Bill 1867, having secured the majority, moves on to Finance, Ways and Means Committee.
Thank you, Mr. Chairman and committee.
Thank you for coming. Item 4, House Bill 1930. I don't see Chairman Vaughn. Do we have a communication? We'll roll it to the heel of the calendar. Item 5, House Bill 2046. We do have a motion and a second on House Bill 2046. Chairman Williams, you're recognized. I don't see any amendments on it.
No, sir, don't have any amendments. House Bill 2046, sorry, wrong bill. I have multiple bills running right now, so I apologize. But this bill was brought to me by the TMA. This is the TennCare provider rate increases that we talked a little bit about already today. TennCare's reimbursement rates to physicians, physician assistants, and advanced practice registered nurses remain significantly below, as Chairman Terry said earlier, of those of Medicare and commercial payers, creating a persistent payment gap that threatens access that was previously discussed. What this bill would do in 2025, Tennessee implemented the Hospital Investment Program to increase hospital-directed payments by approximately $2.5 billion. This program generated significant additional tax revenue to the state of Tennessee. Nearly $150 million has been assessed through this existing MCO tax. This new tax revenue directly benefits the state's general fund and can be leveraged towards increasing provider rates to help close the gaps, to make them closer to Medicare. The strategic investment will help increase patient access, improve workforce ability, and promote long-term economic growth. This bill, what we will hope, it will help us to use that MCO tax monies to help pay providers a more reasonable rate comparable with those of private insurance. That I'm happy to answer any questions the members might have.
Thank you for the explanation. Members, do we have any questions? And Chairman Williams, just for fairness, I had asked you the question why the two specialties are the ones who are benefiting from this. Kindly explain and convince us.
Right. Well, it's generally based upon revenue. These are the two most impacted by those provider payments being what they are. This was brought to me by Tennessee Medical Association. They felt like that these were the two. It doesn't necessarily limit those. It's really creating a funding vehicle by which we can pay those additional rates to
Thank you.
providers.
Chairman Speaker, you're recognized.
Thank you, Mr. Chairman. And just for clarification, because we have people here that we're going to talk to later, your intent with this legislation, does TennCare make these direct payments, or these payments come through the MCO to the provider?
You're recognized.
Thank you. All this does is it utilizes the first tax dollars from the MCO tax to be given to TennCare to improve or increase those provider rate increases, or in my opinion, make them more in line with what's happening across the state for those in metro areas versus those in rural.
You follow up?
And so on a follow-up, just for clarification, your intent is that the dollar amounts that we're paying now, going forward, if this bill passes, they would be increased to these providers. Is that correct?
That's correct.
Thank you, sir.
Thank you. Members, any other questions? Seeing none and without objection, we are voting on House Bill 2046. Clerks, please open the vote. Members, register your vote. Has every member voted? Does any member wish to change their vote? Please count the vote.
Mr. Chairman, you have 15 ayes, no nays.
House Bill 2046, having received a majority of the vote, moves on to Government Operations Committee.
Thank you, Chairman and members.
Thank you. No, let's take Rudder first. We will go on back to item 4 without objection. Chairman Vaughn, House Bill 1930. We have a motion and a second. You're recognized on House Bill 1930. We do have an amendment. Do you have an amendment number?
I do, sir. 014294.
Yes, that's what we have. We have a motion and a second on attaching amendment 014294 to House Bill 1930. All those in favor, please say aye. Opposed? Amendment goes on the bill. Chairman Vaughn, explain the amended bill to us.
Thank you, Mr. Chairman. But before I say that, I see, as looking at this committee today, I see that there are several of us who have paid homage to it being St. Patrick's Day, but nobody has leaned into it like our chairman has. That is a strong showing of your Irish heritage, Chairman Kumar.
It's my only Irish degree, honorary.
Thank you.
Thank you.
Committee, in 2023, we passed Public Chapter 352, which required that an health insurance issuer maintain a sufficient number of contracted providers within its in-network facilities to reasonably ensure that patients have complete and comprehensive access to service. Also provided for a complaint procedure along with that. But in August of 2025, the Tennessee Society of Anesthesiologists formally filed a complaint with the department requesting a review of an insurance issuer's network. And through that process, finding the lack of formalized deadlines, enforcement measures, and transparency made it clear that our patients do not have adequate protection as what we wanted back in 2023. And we also discovered that some issuers of insurance were not complying with the law. So this bill seeks to modify that code. It's going to require CNI to, within 30 days of a request, to review and approve a health benefits plan's network adequacy compliance prior to the plan being offered to the public. It's going to require that each health insurance issuer maintain a network of participating providers, and that material changes to that network has to be reported to the department within 15 days. If a plan is not compliant with adequacy standards, It requires modification within 60 days of finding that and a new corrective action program. Plus, it enables them to file monetary penalties against them. The basis behind this is that consumers need a choice and need to be able to have, rather than being funneled into one provider, there needs to be adequacy of offerers of services. And so with that, Mr. Chairman, I'm happy to entertain any questions.
Well, thank you. Chairman Hale, you're recognized.
Thank you, Chairman. Thank you, Chairman Vaughn. We had asked this question, Chairman, and I don't know if the department is here to comment on this, but I understand that they have just recently set up a new vendor to address this issue. And so I don't know if we want to call them up to speak on that. I know we had discussed that last week, and of course we didn't get to this bill. So to get an answer from them on that.
Yes, we have several people who are available to testify. And do you have a preference? We
Just-
have Mr. Will Kirby and Scott McNally. They're both for the department in opposition. And then we do have an anesthesiologist society member in support of it.
Well, I just know that the department had said 2 weeks ago, or last Monday, I guess it was, that they have just recently implemented with a new vendor to work on this situation and to address this. So I think we need maybe to hear what they've done, and if it's working to address this, if it's something recent, then we need to maybe at least know where we're at with it.
Thank you. Yes, that will be in order. We will go out of session without objection. And are Mr. Will Kirby and Scott McNally available? Can you state your view in about 3 minutes for both of you, or do you need separate 3 minutes?
No. I think we can do it in less
You
than.
will, thank you. We are pushed for time. We
Yes,
appreciate it.
understand.
Kindly, for the record, kindly state your name and who you're with.
Thank you, Chairman. Scott McNally, Department of Commerce and Insurance. This is Will Kirby. So as the sponsor mentioned, Public Chapter 352 was passed in 2023. That was the first time that network adequacy statutes had been amended in Tennessee since 1998, which I think most volunteer football fans in the audience will recognize has been a considerable amount of time. That public chapter took effect on 1/1 of 2024. We had our complaint forms live on 1/9 of 24. So we did work quickly to implement the bill. However, because of the age of the old statute, there was a department understanding that the managed health insurance issuer, which is what that applies to right now, was an HMO because it didn't have any kind of out-of-network providers. So between 1998 and 2023, you had EPOs start to get created, which are, they don't have the managed care model, but they do have a limited zero network benefits plan. So in implementing this law, we wanted to establish whether or not it applied to both. We recognized that it did, put out a bulletin, that'd be 2402 in August of 24, letting all of the carriers that had plans that restricted all reimbursement to one defined network, HMO, EPO, the law will apply to you. And that was, I think the bulletin said that would take place on 1/1 of 25 for filings. But anyone could have complained anytime between then. We did finally get that complaint in August of 2025, and we did not oppose the network adequacy bill when it was run in 2023. The department is not opposed to network adequacy at all. We are just kind of opposed to making this change before we've had a little more time to implement the last one. So we did say existing resources on that 2023 bill. I was the resource. Will was the resource. It was one other resource. We got it done in the 90 days, but I think we recognized that probably we did need a vendor. So to your point, Chairman Hale, we have since onboarded one. It's the same vendor that serves CMS. CMS has network adequacy standards for ACA plans, which is the vast majority of plans that we regulate at DCI. So our investigations really look into whether or not our carriers are following those federally adopted standards. And we found that they weren't in November of 25. So we do have enforcement actions. They are still pending. Apologize for the length of time. It is a new process for us. I assume it will go faster as we get to work on it, but it's kind of the current state of things for us in network adequacy. So.
Well, thank you. You're listed as in opposition to the bill.
We are.
What is your main point in that?
We still would like this process in 2023, the 2023 law that we just finally started implementing in late 2025 due to that first complaint, to play out to make sure consumers are protected. And I guess I could also touch on that complaint came from an anesthesiology group. So when we were in that 90-day period of doing our first review, we were checking with CMS saying, well, what are the standards for anesthesiologists? There aren't any specific for anesthesiologists because they are hospital-based providers. So you use the facility as a stand-in for your hospital-based providers. So our findings were not based on X many anesthesiologists at Y facilities. It was, do you have in-network facilities to serve patients? Because in the No Surprises Act, patients are protected if they're at an in-network facility, actually in or out-of-network facility if it's an emergency. But if they're choosing to go to an in-network facility, regardless of whether the hospital-based provider is contracted, the patient is protected. So those are the federal standards, and we've adopted those in Tennessee.
Thank you. Members, do we have questions? Chairman Harrell?
So how long have you had this current vendor?
It's this calendar year. Yeah, a few weeks ago.
So since January 1?
Yes, sir.
Okay. All right. So do you feel like that this has put you in a better place to handle?
Absolutely.
issues?
Yes, sir.
Okay. So with you being in opposition to this bill, do you feel like it would be fair that we say, okay, we've just implemented this, we've spent this money for this vendor, that it's something that we need to, rather than to react too quick, that we give some time to see if this process works, and then if we come back in a year and we're not in a better shape after having this vendor, then, I mean, do you feel like that's sufficient for us to say?
Yes, Chairman. We think the process is going to move a lot faster with this vendor in place. Now, satisfaction with the process, we would just like to see it play out more before we know whether or not we're dissatisfied with the current network access standards. But so far, it seems to be working, I think, right? Yeah. Yeah. We have adequate tools. Thank you, Will.
Okay. Thank you, Chairman.
Members, do we have any questions for the department? Seeing none, thank you for coming. Oh, you have a question. Chairman Speaker.
And so in regards to the bill,
Yes, sir.
is there anything in the bill that's going to change or prohibit what you're doing right now with the new vendor? Or can it work congruently at the same time?
It's a complex question to answer because network adequacy standards at the federal level are subject to change year to year. So right now, it's really deferential to the department. This is putting new requirements in. I think for the most part, there's overlap, but I want to point out that there are requirements specifically, let's see, we're on 14294, I think, right? Or is that a different
Yes.
amendment? Okay. So on page 10, there's X number of providers at Y facilities that would have to be in place to meet network adequacy. We don't have the clinical expertise to make the determination of how many types of specialty providers need to be at whichever facilities. And the federal standards don't have those because, again, it's just the facility itself that puts a plan with an adequate network if it's in network. So that's one distinction that we would not be able to use our current vendor at our current price anyway to check against. I think we could probably attempt to buy up, but would like to avoid that if we don't have to. So
You're recognized.
Thank you, Mr. Chairman. So I think I understood what you said, that there's only one conflicting part in the bill that would cause possibly have to renegotiate with the vendor. Would we pay a penalty for a renegotiation?
I don't know the contract well enough off the top of my head. And I also want to point out it is a long bill. So that is probably the biggest one that comes to mind, but I can't guarantee that's the only conflict between the current process and the one proposed in legislation.
Okay, thank you, sir. Okay.
Members, any other questions for the testifiers? Seeing none. Do we need? We will go back into session. Do we have questions for Chairman Wan? Chairman Spickett?
Chairman Vaughn, you want to address what was just said there? I mean, do you think there's a conflict here or can they work through it?
Well, Chairman Spicky, I was sitting there digesting what I heard, and it was that, okay, this body brought forward to the administration a bill that addressed a longstanding issue that we felt like that we had. And in response to that, the first time out with it took a while for everybody to see how it worked. And it exposed some things that we found were in practice that perhaps the department wasn't aware of. And the way that we administer this bill. But I think rather than saying, hey, let's do it, even though we've exposed some things in the marketplace that are not the way we want them to, rather than improving the way that we evaluate the problem, keep it status quo for now because you just changed it, even though we exposed areas that needed improvement. And so my request of this committee is that we are constantly searching for the continuous improvement. And if we already see areas that need addressing moving forward, then we're here now to do that. And waiting a year, we're going to wind up, what's the cost of waiting a year? I guess consumers not having the access to the in-network providers that we think should be it. And let me just say this, and I have a little bit of an issue because of the whole payer-provider medical services industry itself. It's not seemingly market-driven. And so I struggle with that we're having to get in there and make sure that we've got enough providers that are in network so that we can judge deem a plan that is adequate for the consumer. And so for that, this is an area, one of the reasons we brought the bill back in 23 was the that's a strong word. Let me choose a different word.
Influence.
The variances that we see in the marketplace.
Okay.
And so my thoughts is that we took it out we created this thing, we took it out for a test drive. We realized that it wasn't really what we wanted, but we've been being told, hey, but wait, it's going to grow on you. Let's wait a year while it grows on you. And this isn't a criticism of the department at all, because we know they've got a lot of stuff going, but that's kind of the way that I see this. And I think that if we're in search of constant improvement, we've identified some areas that need working on. Thank you.
Okay. Any other questions for Chairman Vaughn? You did have somebody who would potentially testify in support of it, but I think you made your case.
Okay, thank you, sir.
Chairman Terry.
Thank you. And I just wanted to follow up on, what was pointed out and that what they said was a conflict or whatever it is about having the adequate number of participating providers. And what they're going by are the federal standards. And they're saying, and what you're saying is that, yeah, because they're using that, they don't have an adequate network. And you have that in the bill that they have to have this for our constituents. And so I think they did specify that they don't have an adequate network. I think that's what they testified to. That's the way I took it. And that's the why the bill is before us. And so I do think this bill needs to go through, even though they have this process. I do think this is an improvement of that, and it would allow our constituents to have these type of providers. And so again, thank you for bringing this bill.
Well, thank you. No further questions, seeing none. Are we ready to vote without objection? Clerks, please open the vote. Members, please register your vote. Has every member voted? Does anybody wish to change their vote? Seeing none, clerks, please count the vote.
Mr. Chairman, you have 17 ayes, no nays.
Thank you. House Bill 1930, having received the majority vote, goes on to Finance, Ways and Means Committee.
Thank you, Mr. Chairman and committee.
Members and those who are waiting to present their bills, kindly forgive us. We're going to have to roll the rest of it because we have people from 10-care MCOs that have traveled a long way and we don't have enough time. So testifiers for the MCO hearing, please come forward. My apologies to the members. Okay. We are here for the hearing and statements by the 10-care MCOs, and for that purpose, we will go out of session. This hearing was requested by our members, and we have representatives of Blue Cross, United Health, and WellPoint MCOs. We would give them each, as promised, 5 minutes, and then the questions can be asked. I have the Blue Cross will go first.
Thank you, Mr. Chairman. My name is Casey Dungan. I am the president and CEO of Blue Care, the Medicaid managed care company for Blue Cross Blue Shield of Tennessee. Thank you for your time today. Good morning, and I'd like to share a brief presentation on Blue Care Tennessee and its mission within the larger TennCare program. I believe the most important responsibility of Blue Care has under this contract is to make sure that the TennCare program can successfully execute the requirements placed on the state to administer the Medicaid program through its waiver agreement with the federal government. Blue Care has been a key partner with the state since the beginning of the program, and I'm proud to be leading a team that has a long distinguished history with the program and a commitment to serve the Medicaid program in my home state of Tennessee. I apologize for the presentation. I'd like to highlight the people that serve the almost 600,000 Blue Care members across the state. We have over 1,100 employees that serve the TennCare program, and their mission goes far beyond the conventional health insured tasks, claims processing, and network building. Our care coordinators are committed to support TennCare members living in their homes, helping them get connected with providers who can assist them with daily tasks, provide necessary home care services, or help them pursue their goals to live more independently in the community. Our nurses also serve as care managers for our members, helping with chronic conditions such as heart disease, diabetes, and pulmonary disease. Their outreach provides our members with an extra level of support to help coordinate their care plans, keep up with needed medications, and provide encouragement to keep them on track with their health goals. In addition, we have larger teams to answer calls from members and providers and educate them on changes to the TennCare program. That's a challenging job, especially so in a highly regulated Medicaid plan. Blue Care has been a part of the TennCare program from the beginning, and while there have been challenges along the way, it's always been a meaningful journey. It's a core program for Blue Cross Blue Shield of Tennessee. As we may all remember, the goal of the TennCare program back in 1994 was to provide insurance for every uninsured person in the state, regardless of income. In 10 years, expenses have tripled, and the program's growth trajectory threatened to take any new dollar in revenue growth to fund the original program design. When the decision was made to enact significant reforms to the program to preserve TennCare, Blue Cross Blue Shield operated the plan with the most TennCare covered lives and assisted the state through a stabilization period as the TennCare program regained its financial footing, a position it's kept through careful financial stewardship from 2006 onward. As programs continue to evolve, we've evolved with it, continuing to support the state through its participation and partnership in innovative programs such as the Choices Program, the Employment Community First Choices Program, and the Katie Beckett Waiver. We've led and learned with the state along the way through value-based care initiatives, and we believe that this long-term relationship with the program has been beneficial as the shared historical perspective provides lessons to prevent a return to the challenging financial environment from over 20 years ago. Very briefly, I'd like to share some relevant recent financial experience with the committee. This graph shows Blue Care's medical costs, administrative costs, and operating income from 2021 to 2025. A few observations. In 2021, medical claims were lower as members were continuing to put off non-emergent care due to COVID-19 concerns. You can see that claims continue to rise from that year forward from $2.1 billion in 2021 to $2.6 billion in 2025. However, administrative costs for our health plan stayed relatively flat during the same period, only rising from $282 million to $294 million in 2025. That focus on containing administrative cost growth where possible mitigated to some extent what could have been even larger losses for the health plan in the years of 2024 and 2025, as operating income decreased from 4.4% in 2021 to negative 1.7% in 2025. These expenditure patterns are not unique to Tennessee, but they're relevant in the context of what TennCare MCOs are asked to do in partnership with the state. Manage emerging medical spending trends to stay within budgeted funds for the TennCare program. Dedicated work in support of this responsibility is what's helped the program remain sustainable over the past 2 decades. This work administrative spending is an investment that brings returns. Unchecked or unmanaged trends in Medicaid program increase financial pressure on state, which can take dollars away from other key strategic investments in future state budgets. Fortunately, we're not currently in the circumstance, but Tennessee does have experience with that set of circumstances. As I close, I just want to take a moment to set the record straight about who we are, what we do, and what we do not do. First, we do not use AI to deny or adjust claims, artificial intelligence. Any clinical review that affects payment or coverage is conducted by qualified clinicians, consistent with TennCare policy and state and federal requirements. Second, we do not own a pharmacy benefit manager and we do not own provider practices. And while we do serve about 39% of TennCare members statewide, we do not market or advertise to TennCare enrollees. Our members are assigned to the state's enrollment process, or they select us at the point of enrollment.
Thank you.
Thank you.
Thank you. Next, we have United Healthcare.
Chairman Coomer and distinguished members of the committee, thank you for granting United Healthcare the privilege to address you today regarding the 500,000 Tennesseans that we serve across the state.
Kindly state your name for the record.
My name is Yuta Strand, and I serve as the local CEO and plan president of United Healthcare Community Plan of Tennessee, located here in Brentwood, Tennessee. With me today is our CFO, James Kelly. As introduction on page 2 of our presentation, United Healthcare is a subsidiary of United Health Group, offering commercial, individual, Medicare, and Medicaid health insurance plans across the United States, to include here in Tennessee. But specific to the TennCare Medicaid program, for which I am responsible and can only speak to, I have 544 employees reporting to me who provide service to our 500,000 TennCare members, and of those employees, 4 are licensed MDs in the state of Tennessee. United Healthcare's community and state Medicaid division serves over 6 million members across 32 states and Washington, D.C. But even with our size and experience, we're dependent on a much larger healthcare ecosystem to ensure that we consistently and compliantly deliver well on our managed care Medicaid programs, to include TennCare. Let me explain by going to page 3 of our presentation. This inverted triangle speaks to the Medicaid managed care ecosystem that defines who does what. Starting with the specialized medical societies, which includes bodies of specialty physicians who define what is appropriate care for their respective specialties. The AMA, the most influential physician-led coding body in the US, defines how services are coded and defines the CPT codes used to bill for services. CMS defines how services are paid and has stringent audits to ensure compliance across the process. States, to include Tennessee and TennCare, define and administer Medicaid eligibility and benefits within federal rules. And so as United Healthcare, we bring together all of this information to create our policies and procedures that inform our authorizations and claim payment processes to ensure that our members receive the right care in the right setting at the right time for the best outcomes for their individual needs. And in the interest of time, the rest of the slides speak to the benefits of managed care versus prior years fee-for-service, but I do want to cut straight to page 6 of our presentation to speak to our financial performance. James?
Thank you, Yuta. What we have presented for you on this slide represents the financial results for United's TennCare operations for the last 2 calendar years. These figures were pulled directly from the MCO financial reports, which are available at the link at the bottom of the page, published on the Department of Commerce and Insurance website. These graphs represent the percentage of premium dollars and where those monies were spent for the last 2 years. You can see that for calendar year 2023, 88.5% of the premiums were spent on direct medical care for our members. This figure is commonly referred to as medical loss ratio, or MLR. 10.4% of the dollars received were spent on administrative costs, leaving us with a net income of 1%. For calendar year 24, the MLR rose to 89.7%, while administrative expenses stayed relatively flat, resulting in a net loss for United of 0.3%. Lastly, I'd like to just address medical loss ratio. MLR is essentially the percentage of premium dollars spent on direct member care. In our contract with the state of Tennessee, at least 85% of those dollars must be spent on medical care. If anything is below 85%, that is returned to the state of Tennessee or reinvested in TennCare approved initiatives. So with that, thank you, Chairman and members of the committee, for the opportunity to present for you today.
Just for completeness of records, state your name.
I'm sorry, I thought you'd have covered it. James Kelly, CFO for United Healthcare of Tennessee.
Thank you. We have WellPoint next.
Thank you. Pull up my slides.
Again, for the record, state your name and who you're with.
Thank you. Good morning, Mr. Chairman and members of the committee. My name is Rachel Chinetti, and I am the president and CEO for WellPoint Tennessee. I have 20 years of experience working in both local and national Medicaid programs with a specialty in LTSS, and I am a proud Tennessee native. I'm joined to my left by our Chief Financial Officer, Donnie Estes, who has 35 years of experience in finance, spending the last 10 years in Medicaid with WellPoint. Our mission at WellPoint is simple. It is to transform healthcare with trusted caring solutions that really put people first and deliver strong value for the state of Tennessee. We do this through our 526 associates that we have across the state, and that includes our dedicated case management teams that provide case management and care coordination to members with complex healthcare needs such as high-risk maternity, long-term services and supports, and behavioral health support needs. By design, these case managers are local with deep roots in their communities. These are local nurses and social workers who are meeting with TennCare members in their homes or in care facilities to have one-on-one conversations and really understand and address their individual personalized healthcare needs. Along the bottom of your slide, you'll see noted that we have been working with TennCare since 2006, very proudly so, and have had the opportunity to observe TennCare as they focused on modernization and optimization, implementing key initiatives such as behavioral health and long-term services and supports into managed care through the Choices and Employment and Community First Choices programs. We've also seen numerous payment initiatives that really focus on aligning pay with the outcomes that we want to see in healthcare programs. And then most recently, we've seen a real tremendous focus on alignment between Medicare and Medicaid programs to ensure that TennCare members have one care team and one care plan, really simplifying what can be a complex process to navigate between payers. All these things collectively demonstrate TennCare's focus on person-centered planning and high accountability for Medicaid, and also aligned to the value of managed care as a whole. And I'll talk a little bit more about the value of managed care on the next slide. So a key strength of TennCare's managed care program is our whole health approach. Managed care organizations are able to coordinate care across a full spectrum of supports, including things like physical health, behavioral health, and long-term services and supports, rather than treating each of these areas in isolation. So through a coordinated approach, a managed care organization really addresses individuals' complex needs early, right? Engages across the spectrum of their support needs, which support in addressing and providing the right supports, the right providers early, and ultimately prevent more serious and costly health issues down the line. By focusing on prevention and care coordination and accountability, managed care helps improve health outcomes while ensuring responsible stewardship for taxpayer dollars. To further promote accountability, I would just add that TennCare maintains a detailed and prescriptive contract that clearly outlines expectations for how managed care organizations are to perform. TennCare closely monitors this contract, monitors our performance through this contract with robust reporting, auditing, and even community-based care coordination ride-alongs to ensure that they're evaluating managed care clinical outcomes as well as financial stewardship. And one note I would just make is that prior to taking on my role as president of WellPoint, I served in a national Medicaid role, and I had the opportunity to work with regulators across the country. And through that experience, I can say with confidence that TennCare is a known leader nationally in accountability for managed care Medicaid.
Well, thank you. Members,
Oh.
you heard a snippet of the functions. Do you have?
I have just a couple more slides, Mr.
Oh.
Chairman, if you don't
Oh,
mind.
okay. I thought
I
you
won't
would-
take too much longer. Thank you. Okay, so I wanted to provide a little bit more information about WellPoint specifically. We serve more than 412 members statewide through TennCare programs, and remain focused on achieving quality through NCQA a quality accreditation, which reflects nationally recognized standards for quality, member protections, and care coordination. We also focus and measure member satisfaction regularly, which reflects with a 90% accuracy of live agent calls within 30 seconds, reflects our commitment to member experience. I also want to talk about investments in care. Our medical loss ratio, or MLR, which reflects the percentage of every dollar that goes towards members' care, averaged 87.1% in 2025. And again, as my colleagues mentioned, what this means is that nearly 87% of every dollar received was invested directly in healthcare services for TennCare members. A strong provider network is essential to serving TennCare members effectively, and today we partner with approximately 5,000 primary care physicians, 17,000 specialists across Tennessee, and over 1,000 long-term services and support providers. In terms of relationship management and performance, we have processed around 8.1 million claims, and we also do not use any AI to deny claims through our claims process. We also regularly engage with providers to support connection and issue resolution, conducting more than 1,700 face-to-face provider meetings in the last year, and over 400,000 provider town halls. And I will close now, but appreciate the opportunity to present in front of this committee. And we will now, I believe, open up for questions.
Well, thank you. Members, do you have questions? Chairman Martin, you're recognized.
Thank you. How many questions can we ask at one time? There's a lot. Thank you guys for coming. I greatly appreciate it. You guys are obviously on the hot seat compared to if you've watched committee thus far today, but I appreciate you guys coming and taking these questions. It's important to us and our constituents and our providers going on. I believe WellPoint addressed this, but can you go through and explain that you through how long you guys have been associated with TennCare and utilizing your umbrella you purchased or you as your individual right now?
Yes, thank you for the question, Representative. I have worked for United Healthcare in the Medicaid space since 2007, supporting the TennCare program. Our company has, similar to the other two, procured the current contract since 2006.
Yes, and I've been, Casey Duncan again, I've been with Blue Care since 2019, and Blue Cross has been a partner with the TennCare program since the beginning in 1994.
One of my concerns that I've heard continually and we talk about is the lack of provider communication. And I know we've talked a lot, you guys have saved a lot of money, you've got satisfactory from the client, the patient, but my concern as well is the provider outreach and what you guys are doing to address our concerns, what we're having. Many practices have 3, 4, 5 employees all day long dealing with denials, dealing with issues through TennCare, trying to get communication back from our MCOs. It's unbelievably frustrating when we literally have to have people there to call you guys. I've got one in particular in my community. It took 8 months for one of the 3 to actually get back with a contract that they need to pay their bills because they also are insured by your umbrella that's also not getting covered. So my question is, what are we doing to better communicate with our providers that are doing these services for our constituents to make sure, 1, that their voices are being heard, 2, that we're actually paying the bills, as we've talked about, rural healthcare is getting reimbursed at a much different rate than our urban centers. So what are we doing to better serve the provider to make sure that the patient is the center of the focus and we're addressing their concerns?
I may answer first from the Blue Care perspective. You know, we do have dedicated provider teams, and their purpose is to outreach and make sure that on the whole, that does not happen on a regular basis. So when I hear that concern or that complaint that that's been experienced, that is an issue for me. I had a conversation just last week with a provider that had expressed some confusion perhaps on how to navigate the administrative process. And we take it very seriously. So I stepped in to try to remedy it and then tried to follow the line back to see where the ball had been dropped. We do try as best we can because we know it's so important to make sure that if you're going to do the work to participate in network, that there's someone that you can reach out to. So someone should be dedicated to that provider. And I would research any concern that anyone raises with that, because it's very important to make sure that the network is understanding where its position is relative on such important matters as contract. But also, as I've mentioned before, just it's a very, it involves a lot. The Medicaid program does as well. And there are some complicated programs. So it's important that providers in our network are supported that way. We have dedicated resources for that, but I share your concern when you find that.
I would echo Casey's comments around dedicated staff for provider supports. And that is not just one global team, that is across different provider types, including specialized providers for behavioral health providers, long-term care providers, et cetera. To Casey's point, our intent is to be accessible partners for our providers and the services that are provided. The foundation of TennCare programs are not successful if you're not successful in partnering. So just fundamentally challenges accessing our staff is counter to what we intend to do. And similar to Casey's comment, that's something that we would absolutely seek to follow up. I would also note that TennCare holds us accountable for quick responsiveness. And that's another one of the areas that they frequently audit us on as well.
Yes, and from United Healthcare, I echo my colleagues in that we are very compliant with our contractual requirements related to member and provider call center results. And we do have dedicated staff that supports our Tennessee providers as we take, again, these relationships very seriously, because TennCare members are some of the most fragile Tennesseans that we have. And so we want to partner quite closely with our provider community. And like Casey, I will get involved personally, as will members of my immediate staff, when we hear of escalated issues that need resolution. So if there are examples, I welcome them.
Well, thank you, everybody. Sounds very reassuring, and we appreciate it. But from a practical point of view, for a provider who's dealing and advocating for a patient and 8 months go by trying to get somewhere, or do you have suggestions?
They can reach out to any one of us directly. We are all local here in Tennessee, and any one of us at the CEO level will handle a situation that takes as long as 8 months, because that is not the usual practice.
So the CEOs are that available.
We are that available.
We are that available.
We heard it here. All right. Chairman Mark?
Thank you for your responses. I've got plenty more, but I'll let some others go first and you come back.
Very well. Chairman Hill, you're recognized.
Thank you, Mr. Chairman, and thank you all for being here to present and to testify. I think part of the concern, but before I get to my comments, it was mentioned that Blue Care has been with TennCare since the inception. How many other states with the MCO model are there? Let me say it this way: are there other states or any other states that use another model when it comes to their state Medicaid program? And the reason I asked that question, and maybe you all can answer that, I think what some members on this committee are hearing from their providers and ultimately the patients that it affects is that the MCO model needs to be reviewed. And that's a big statement. And that's a big thing to say. Because it is, we find ourselves in a position that it's a layer of government on top of a layer of government on top of a regulatory layer on top of this, on top of that. And eventually we call it network adequacy, but what we're really saying is we're saying patients can't get the help that they need. And what we're really saying is that we're saying that on my end of the state, we've got patients, people that are having to travel hours and getting a reimbursement from TennCare for their mileage to get into a place where they can provide or get the services that they need, get the help, get the care that they need. And in that scenario, my assumption is, and you guys tell me, but my assumption is well, we're not able to reimburse enough, and so we can only serve so many people, and that's again perhaps an oversimplification, but the question I think that this committee is going to be faced with over time is all of these different layers. Is it the appropriate approach? And then again, it was my privilege years ago to carry the block grant bill. And it comes up a lot in this insurance committee. It was a groundbreaking concept. I'm no genius. It's been tried before. But I think Tennessee may be in a posture because of the relationship with the MCOs, with the providers, and the providers with the patients, and the lack of the ability to get reimbursement, that we need to look at the overall structure of TennCare. And my question is, what would the impact on our patients, and again, those are big hypotheticals, but the reason that we're there is because we keep having concern after concern after concern after concern. And so I guess I don't necessarily have a question right now. It's more of a statement that we're grateful that you all are here. I'm grateful that you guys are here, but I'm not convinced that the MCO model is appropriate for healthcare in 2026 and moving forward. So thank you, Mr. Chairman.
That is serious food for thought for the MCOs as well as those of us on the committee. In interest of time, we would move on to Chairman Spicky.
Thank you, Mr. Chairman. You're here today because things are not going well. That's why you're here, because we hear from our providers, our hospitals, our constituents, that this is broken. It doesn't work. It's not working right. If we could have a meeting with the providers, the hospitals, you, and then TennCare sitting behind you, where we could get the correct answers, because when we had TennCare here, they said, oh, it's not us, it's the MCOs. Talk to the MCOs, no, it's not us, it's TennCare. It's the providers, it's the hospitals, it's the system. My colleague from East Tennessee, I agree. I think we need to open this MCO up and let the market compete like other states have. I would sign on to that bill in a heartbeat.
Chairman Spicky, are you making a case for another meeting with MCOs and TennCare together?
Boy, I love it, Mr. Chairman. Here's the biggest problem I see, and this just arose from artificial intelligence. And I know you don't use artificial intelligence to make the decisions, but you use artificial intelligence to influence the people who make the decisions. And I'll tell you how it works. And I know this because I've talked to people who work for you. And here's what they've told me. If everybody sitting here in the old model is evaluating claim after claim after claim after claim, I'm picking up the next claim, I'm looking at it objectively, I'm checking to make sure it works, and I'm either saying, yes, it's fine or not, period. But you've changed the dynamic. And you've changed the dynamic using artificial intelligence, that now the people sitting here evaluating the claims are only evaluating the claims that AI has said there must be something wrong with. Now you've changed the human element of how I'm looking at these different claims. If we sat here as legislators and the only bills we considered were ones that AI said, oops, there's something wrong with them, you better try to find it. How many bills would get through our committee? Very few. AI is Republican. I've been serving on this committee for 8 years. We have passed, Mr. Chairman, we've passed bill after bill after bill to fix this problem. We just passed a bill on PBMs. We just passed Chairman Vaughn's bill. We will continue to pass bills to fix this problem. I think the only way to fix this is to maybe require the executive leaders of these MCOs to be on TennCare for their insurance. And let them experience, as a patient, going to a TennCare provider and seeing the frustration that the TennCare providers have in dealing with the MCOs. And maybe that's a bill we run next year that says the executive leaders of the MCOs have to be on TennCare for their insurance. There was no question there, just a comment. Thank you, Mr. Chairman.
Thank you. Representative Raper.
Thank you, Mr. Chair. And I just have one brief question for United, please. Are you currently using AI to make decisions about patients accepting their whether they get coverage or not, or surgery or benefits?
We absolutely do not use AI to make any clinical decisions on behalf of our members.
Thank you.
Chairman Terry.
Thank you, and thank you guys for coming today, and obviously being put on the spot and seeing the frustration obviously is not comfortable. But you know, with some of the comments that we've had today, and obviously one of the bills earlier that y'all heard with the big gap, $138 million gap of payments, you know, and then with the way that you guys have your contracts with the state and the lack of transparency and because of proprietary information, I understand all that. But with some of the discussions, obviously we know, you guys know that there's frustration. And oftentimes the response from providers is to give us a call and then we have delays, or you want us to give you calls and there's delays. And so the challenge, I mean, obviously we're talking about bills for next year too, but the challenge that you guys have is not the phone call. We need solutions, and we need solutions that are going to help our providers and our patients. Solutions that, you know, if there's lack of transparency in this system, give us solutions that give us that information. So if it's so that we're not, you know, maybe making assumptions, I don't know, but we need that information. But give us these solutions, work with us. You know, if we're going to change the system, you know, better be part of the solution than to have it completely blown up. So that's my challenge to you guys. When you leave here, figure out some solutions that are going to help our patients and our providers. Thank you.
That is certainly a point, because we're not going, the problems we bring to you are not new. You've heard them before. So, but at the same time, you hear our frustration that you know the problems, yet the system is not working to satisfy the providers and the constituents. So you're familiar with the problems. Now it's a matter for you to draw the solutions. And I think at the next communication, we will see how that works. We would like to hear, what problems do you think we have, or the TennCare members and providers have, and what solutions do you have proposed? In the interest of time, the last person, Representative Hakeem, you recognize.
Thank you, Mr. Chairman, and I'll be brief. As I listened, I think we were talking about responding to claims, and I believe all of the entities before us have dedicated people, you know, to deal with those kinds of concerns. And I guess Chairman Terry and Chairman Kumar and Sapicki, I think we're all on the same wavelength. We're not here to try to destroy you, make you look bad. If there's a way of the system working better in the interest of our constituents, of the providers, we're more than willing to work with you on that. And I'm trying to say it in such a way that we're not blaming you, but we need a different way of accomplishing the goals that we're looking at. Thank you, Mr. Chairman.
Thank you. Representative Parkinson, the last word.
Thank you, Mr. Chair. Instead of us running legislation to put these MCOs on TennCare, I think we need to run legislation to put all of the members of the General Assembly on the safety net. And then I think, we expand Medicaid at that point. I do want to say this to you, y'all, it's okay, y'all can laugh at that. I do want to say this to our our visitors. I think that, and to you, Mr. Chair, also, I think that we're looking at, I don't think our scope is big enough. I think we're looking at, one part of what is a very or somewhat complex problem that's pervasive in healthcare, period, in the entire country, and it's affecting us here in Tennessee also. And I think we're just looking at one small part of it, and looking at what's happening with our MCOs, because I think some of these situations may be situations that may be forced or from another space in our healthcare system in our state. I think it's important that we ask why some of these claims have jumped or spiked in the last few years, right? And I think then we can ask why they're reviewing spike claims. Then a lot of it's happened since COVID. We don't know what the lingering effect was coming out of COVID. Also, I think we also need to look at what's happening from a standpoint, from a patient standpoint, right? And with AI, patients now can look up, and almost self-diagnose, and then go to a doctor and say, hey, I'm having these, issues, so on and so forth, this, that, and other. But I've seen where people are being treated, this, that, and so there may be an expectation of care coming from a patient also, possibly. And so I think we need to look at it holistically and not just point the finger at one area, but look at all of the areas and then, pull them all together possibly and have a conversation that way, Mr. Chair.
Thank you
so much.
Thank you, Mr. Representative. Members, thank you for your patience. Thank you for coming. I feel we are not complete, but it's an early food for thought, and let's work on it. After all, we want to serve the members and the providers who provide the care. Thank you very much for coming.
Thank you.
Thank you.
Members, we'll go back into session, and without objection, we are adjourned.